Well, thank you, everyone, and welcome. My name is John Fielder. I'm the co-founder and chief executive of African Mission Healthcare, which, as many of you know, is an organization which handles the kind contributions of many people like you to help Tom in his work. And we also help with procurement of medicines and supplies and help with his students. I want to thank SP for helping facilitate tonight's uplink, and so that we take advantage of the time we have available. I won't delay any further, and I think everyone knows our guest of honor tonight, Dr. Tom Catena, Medical Director of Goodell Mother Mercy Hospital. So Tom, just tell us how you're doing, how are Nasima and Francis, how are things in Nuba?
Everything's going very well, John. Yeah, work's been very busy. I've had a touch of something this week. I don't know. I think it's just another malaria, just the joint pains and fever and headache. Nothing too bad. But besides that, things are going very well. Very busy. Lots of people coming from the government-controlled areas, since that pathway is a bit open. Lots of weird and wonderful surgeries and all kinds of complicated cases. Work's going well. Nasima's doing great. She's starting nice tonight. Francis now is outgrowing his clothes and doing great. So everybody's doing very well.
Tom, you mentioned that people are coming from the government-controlled areas. I'm wondering if you could lay out for everyone. It's often confusing. You know, where exactly is Nuba, and what does that geography mean for the people there and for the hospital?
Yeah, just to answer your question, Nuba Mountains is part of South Kordofan State, and we're located in Sudan, not in South Sudan. We're in the southern part of the Republic of Sudan. The area is about the size of Austria or Georgia, population of about 1 million people. And we've been in civil war since 2011, kind of a separatist movement from the government. Now we've been in ceasefire for a few years. Situation's calm, but there's still no peace agreement with the government. So things are still a bit dicey here. So government-controlled areas are areas that are controlled by the Sudan government. Our area in the mountains is called SPLA North Controlled Area. SPLA stands for Sudan People's Liberation Army North. And these are the SPLA rebels that fought in this previous civil war against Sudan for the 20-some years, from 1983 till 2005. That civil war continued here in Nuba from 2011 until this current day. So when I speak of government-controlled areas, these were areas that were completely off limits to us for the past 10 years. Those people could not come to us, so we cannot go to them. Now there's a bit more freedom with the ceasefire, and they're allowed to travel to seek our health services. And we're a rural mission hospital, and what they can get from us is far greater than what they're getting in the Republic of Sudan. So they're really flocking to us for what we can offer them.
Say something more about that. When you say it's better than they can get in Sudan generally, I'd heard that people were even coming from Khartoum, in the capital in the north.
Right. So I guess the scene in the north is they have, for instance, Khartoum, all the resources and wealth and everything is in Khartoum, which is the capital, about 3 million people. Outside of that, the services drop way off. And the problem people have is you might have a small or even a larger district hospital in one of the towns of the north, but you might not have personnel. You definitely will not have drugs and supplies there. If you find a doctor, and there are plenty of good doctors in the north, if you find one, they're going to charge you quite a bit of money to have anything done. So what we find is people will come and say, okay, I found a doctor in Khartoum that could do it, but they couldn't come anywhere near to affording it. So a lot of it boils down to both access to care, access to decent drugs and supplies, and then affordability. So people are willing to travel from Khartoum, which is usually a 3 or 4 day journey, to reach us just because they can't afford to go to a hospital in Khartoum. They have the services there, and they have some of the equipment and other things to get things done. People just can't afford it. The economy in the north is terrible, and people just cannot afford the healthcare.
You mentioned the surgeries that you're doing. You know, uh, you're trained obviously as a family doctor, so you have a broad training, but tell us how you came to actually learn surgery and why you spend so much of your time doing surgery.
You know, when I first came to Africa, John, I first arrived in Kenya in January 2000. So I've been now 21 years and a month in Africa. And I trained in family practice, as you said. And when I first arrived in Kenya, I realized that a lot of the work that you need to do as a mission doctor is surgical. I mean, of course, you have all the maternity and the children and all that sort of stuff, but you've got to incorporate some kind of surgical repertoire into what you do. So I just started basically looking for mentors, looking for people that would teach me how to do basic stuff. Started out with learning how to do minor procedures in Mutombo Mission Hospital in Kenya, and then ended up in northern Sudan, northern Kenya, and then in Nairobi, where I had a couple of surgeons there that were willing to take time and really teach me all the basics of surgery. One guy in particular is a guy named Mike Johnson, who's an African-American surgeon, missionary surgeon for many years. Mike's back in Philadelphia now. And Mike really taught me a ton of surgery during those 5 years in Nairobi. And I'm always indebted to Mike for taking the time to teach me. Everything from, thyroidectomies to bowel resections to anastomosis, all this stuff I had to learn. And Mike really did the bulk of the teaching during that time. I was very fortunate. Of course, as a mission doctor, we see the hand of God at work here. I'm very fortunate to have Mike there to take his time to show me these things.
Tom, I just have to say we share that connection somehow to Mike Johnson, because one of my dearest friends and someone who's been so important in my life, a Kenyan colleague, I came into contact through Mike Johnson. So he's an incredible person.
Stand-up guy.
We've had a couple of questions that came in before the session, and others are welcome to put in the chat box, or if we get time toward the end, we try to accommodate as many questions as we can. So one of the questions was if you could talk about, of course, we all hope you're going to be there forever, but the question was, what is the sort of succession plan, or how are you preparing for a time after Tom Catena?
Mm-hmm. Well, I think financially, it's like, I guess I look at it two ways, John. One is a financial succession, and the other is a personnel succession. So in terms of financially, we're trying to build partnerships now with a couple of different partners. One, of course, the main partner is AMH, of course, which is you and Mark and Scott and everybody else is involved. And that's our major partner. Besides AMH, we have Sudan Relief Fund with Neil Corkery and David Tony, been a huge help to what we can do. We have Samaritan's Purse, which has offered us a huge helping hand along the way. And others, Catholic Medical Mission Board, under whom I'm a lay missionary for many years. So we're hoping with that we can continue with these partnerships, and we can continue financially to keep the hospital adrift. In terms of personnel, we started with the succession plan many years ago. And the idea is that we would train people, both on the job trained and more specifically to send people to school to develop the skills whereby they could come back and then run the hospital. So that's paying dividends finally. We've got, I don't know how many, 20-some trained nurses and midwives that we've sent out to school, most of whom have gone to WOW. There's a Catholic Health Training Institution in WOW where our nurses and midwives have trained. They're all back now working with us. We've got, I think, 10 clinical officers that we've sent for training that are now back with us, and they're doing a fantastic job. We've got one medical doctor, Martin Cody, who's back working with us now. We have 2 more in the pipeline that a year from now, they'll be back with us working. And I think looking forward, especially these 3 medical doctors and the clinical officers, this will be the leadership class of the Mother Mercy Hospital into the next 20, 30 years. When I'm long gone, we hope these will be the guys that will take over and keep running the show and keep carrying on with the work.
And for those who may not know, clinical officer is like a physician assistant in the United States, and they really provide the backbone of primary care in most African countries. Tom, along those lines, could you talk about the Health Training Institute that you're sending up and why you want to do that? How is it different than what you've been doing in the past?
Right. So, I think what we looked at was we've sent a lot of people out for training, and it's been great. We've gotten great people back, and they're working and doing a very fine job. But it's still for the greater NUBA, even for us at Mother Mercy and for outreach clinics, it's still a drop in the bucket. So I think to really have an impact, the only way to do it is to start our own school and really train our own people in the way we want to train them, and really crank out a good number of trained clinical officers that can really get out to the rural clinics where they'll have a huge impact on primary health care at the village level. I think that's kind of the next step that we're looking at. So not only clinical officers, which again, as you said before, John, like physician assistants or nurse practitioners, but midwives and eventually nurses. I mean, a few years ago, we got Elizabeth back from school, and she's the first trained midwife in the NUMA Mountains. I mean, you got a population of 1 million people with one trained midwife who's gone to school and been officially trained as the midwife. She was it. And now we've got several more that have come back from school. But really, all the clinics that are out there, all the government clinics, whatever, would really need a trained midwife to have a really big impact on maternal and child care. So I think that's the next logical step we need to do. This has been the work of mission hospitals for millennia, where they come, they establish a hospital, they start training programs. So we're really following the model of really all the mission hospitals that have preceded us, and how they've trained staff and come up with plans how to better the health system in their area.
And what's it going to look like? I know that you guys have plans to start the building soon, but what are the buildings going to look like? The teachers, how's it going to run?
Mm-hmm. We're looking at a very simple setup. Probably just a couple classrooms to start with. Two buildings, maybe another building has a kitchen. It's a very beautiful piece of land where the community has given us a nice piece of land where to put it. It's kind of set in the mountains. It's really very pretty. So very simple in terms of building structures. Try to focus more on getting quality tutors. We've got a few people with us now. Another missionary couple that's with us. Another missionary nurse that we will have as tutors. Sister Anita, who's our matron, is also a trained tutor. We'll probably have to hire another tutor, either from Uganda or Kenya, most likely Uganda, to come and join us and do the bulk of the teaching. And then use our clinical staff, our clinical officers, and our midwives as kind of adjunct faculty to both teach classes in the classroom, but more importantly on the wards and in maternity and on the clinics, to be sort of adjunct professors there teaching. So we have kind of a basic network of people that we can already tap into for teaching. I think a lot of our didactic stuff will be things that'll be online and this sort of thing. Not a lot of physical books, but more things that are on tablets and that sort of thing for their reading and that sort of thing.
A couple people have asked, what's your typical day like now? Many people know about your work through the journalism of Nick Kristof and what it was like back in those days when the war was really raging. What's a typical, if there is a typical day like now? I mean, you mentioned these crazy surgeries. What are those kinds of things? Right.
So we still have, typical, the week schedule is Monday, Tuesday, Thursday, Saturday are full ward rounds, followed by clinic. Wednesday and Friday are operating room days when we just operate the whole day. We're mostly scheduled and any emergency that comes in. So say, typical Monday, you get up and we have, my wife and I start the day with our daily mass. We're fortunate to have a priest with us, and mass starts around 6:30. So we go over to the parish, which is just about a 10-minute walk. We have mass from about 6:30 to 7, come back home, have a bit of coffee, go to the hospital, start rounds about 7:30, and start the rounds on maternity ward and do a full round there. Go from there to children's ward, do a full round of children's ward, go to the female ward, do a full round there, then up to male ward, do a full round there, and then go to clinic, and then see a whole bunch of people in clinic until we finish seeing everybody, then go home and then take call at night. It's gotten a bit easier from before, like when Nick Kristof was here, because now we have the clinical officer interns will do kind of a pre-round on the patients. So they'll go and see the patients. I'll join them on the rounds, and then we go and review all the patients with them, which has been great. It's a great learning opportunity for them. It gets them really engaged in the inpatient care, and makes it a whole lot easier when they've already gone through and done the hard work of talking to each patient, get their complaints down, and kind of go through a review of what to do that day for them. So it's gotten much better. Clinic is still, still pretty much a slog. Still large numbers of people and everything we see there. Operating room days, we just go and do a quick round, just kind of put out fires in the wards and try to get to the operating room by about 8:30 or 9. And then we just start going through all the cases and try to finish at a reasonable time. Usually we finish around 5:36. And we'll do anywhere from 15 to 20 cases. That's both major and minor, and a pretty big variety of things that we'll do that day in the operating room. And then the rest of the night, weekends, days are for emergency. So any emergency operation that comes in, we're ready 24/7 to do that. So those come at any hour of the day or night.
One question that came in, Tom, was can any of those who have returned from their training, can any of them do surgery?
Right. So now the way I was trying to structure it was, for the most part, the clinical officers have been focused mostly on outpatient care. So, primarily I want them to be experts at clinic. And that's how we modeled it. And I was saving kind of the surgical stuff for the medical officers that come back. So Martin Cody, who's now back from school, I'm training him now in C-sections, hernias, ectopics, hysterectomies, what else? All the minor procedures. So DNCs, abscess, suturing wounds, fracture reduction and POP placement. So we're slowly getting him worked into all the sort of major minor surgeries. So he'll be fully proficient at minor surgery and start to take on some major cases. So I'm getting him up to speed on those operations. And with the other medical officers that come, when they finish, start doing the same with them. So kind of save the surgical stuff for the MOs that come back and get them up to speed on surgical stuff.
And, throughout all those patients, I mean, the inpatients and the surgery and the clinic, about how many patients is that a day?
If we do a full ward round, including up in TB Village, it'll be, 350 patients that we'll see on ward rounds. Clinic will be, 50, 60 on a busy clinic day that we'll get through, that I'll see. And almost all those in clinic are referrals. So clinical officer sees them, and then they, refer to me as the consultant. Whether it's, something they don't understand, or, sometimes patients come, they say, no, I need to see the big doctor. So the COs get frustrated. It's okay, go see the big doctor. Then I'll see him then. But it's a good number of people to get through. But yeah, I've gotten used to it, and our staff have gotten used to the pace and how to kind of get through the numbers, hopefully in an effective way, that we're not ignoring their major complaints. But we really try to do the best we can with that big number. I'm hoping that, it's gotten much better, John, because now, like Martin, who's a medical officer, I'll have him start on the men's ward, which is a very busy ward. He'll start rounds there. So when I finish the other few wards, I'll join him, and he'll just kind of go through patient by patient what the issues are. And it's much quicker. So instead of like a 2-hour slog through male ward, now it's a half an hour, just kind of reviewing everybody. And he's doing most of the grunt work on the ward. It's gotten much, much better. And I hope that will continue going that way.
Well, that's really good to hear. I think I can't really do justice for our audience. I have rounded with Tom a couple of times, and it's a sight to behold. Not only the sheer volume of patients, but the variety and the things that Tom has to manage and is capable of managing. I mean, I've seen him manage everything from the kinds of surgery conditions that he's mentioned to really rare autoimmune conditions, and of course all the usual infectious diseases and leprosy. So it's an incredibly diverse array. Someone asked, are you doing eye surgery?
Right. So, for me personally, I'm limited. I'll do enucleations if someone's got an eye tumor or a blind, painful eye. I'll do enucleations. I'll do lateral tarsorrhaphies. Tarsorrhaphy is an operation where you kind of just basically stitch shut the lateral part of the eye. And we'll do that for patients with leprosy, because one of the problems with leprosy is they can't close the eye fully because of the nerve damage to the seventh nerve, and they get corneal ulcerations and pain. And some evisceration, some minor stuff. But the good news is we sent a guy through the help of African Mission Healthcare, one of our clinical officers, Caesar Elia. So Caesar went to Tanzania and got trained as a clinical officer ophthalmologist. And he is now doing cataract surgery. And he's doing a ton of them now and doing great. So he just got back last month in January. And he's done a ton of cataract surgeries now in the past month. So, I mean, like for us here, this is a huge step forward. We have a guy trained in doing cataract surgery. Really a big plus. So Caesar now is handling cataracts, and then some of the other eye cases he's doing. I'll still do the enucleations and kind of easier eye surgeries. And I'll let Caesar handle the cataracts and other stuff. So it's been a big step up for us to have Caesar back with us.
Tom, for everyone on the call, Tom used the term a couple of times, medical officer. We talked about a clinical officer is like a physician assistant. A medical officer in the African setting is someone who's gone to medical school and done a year of internship. But then most doctors, that's where their formal training stops unless they get an opportunity to go on. It's not like the US where you basically are, guaranteed to do a residency that's funded in some way by the government. So unfortunately, most doctors don't get the opportunity to go on for further residency. So Tom's working with one of those medical officer graduates now. Tom, we have a question about someone would like for you to paint a picture of the people and the culture in which you work. What are their core values? What do they hope for? What are their dreams and aspirations of the Nuba people?
Yeah, the Nuba are extremely unique people in many ways. The origin is a bit shrouded in mystery. It's very interesting because they've got, I think, 6 or 7 different language groups, and each language group is quite different. So it's thought they've come from different parts of Africa, maybe some from Northern Sudan, some maybe from West Africa, and they ended up in these mountains as a place of refuge, whether they were fleeing from the Arab marauders back in the year 700, 800. They all ended up in this place of refuge. The Nuba is a collection of sub-tribes, and there are supposedly 100 different languages within this place the size of Georgia. 100 different languages. Like for us, where we are, you literally cross over a small mountain, and the other side of the hill, those two people cannot communicate with each other in their mother tongues. They've got to speak either Arabic or English to talk to each other. Totally different languages. And, basically like a half an hour walk, you can't communicate with that person unless you speak, a different language. They don't speak Arabic or English. The people are incredibly tough, I think, given their centuries of oppression and kind of being beaten down by outsiders. They're incredibly resilient. They've been through, the average person here in his or her lifetime, if you're somebody who's in your 30s or 40s, you've already lived through 2 major civil wars, incredible famine, times when you've had no water, no school, nothing, absolute nothing, deprivation. And they've made it through all that stuff and have thrived and are able to keep a positive attitude and keep moving forward. I mean, my wife is from Nuba, and, she remembers growing up and in the middle of the night, her parents coming and saying, okay, the Arabs are coming, and whisking them away and running off to some distant valley where they would spend several days waiting until they cleared the Arabs out and they go back home. She remembers, childhood friends dying of starvation. So she remembers, people being shot in the marketplace. So things that are totally out of our way of thinking are commonplace for people here. So because of that, they're a very tough and resilient people. I think they very much value loyalty. Hospitality are sort of core values of the people here. They're a wonderful people. I think what says a lot about people is anybody who's ever been to Numa Mountains, nobody ever has said, I don't want to go back there. Every single person I met who's been here from outside has wanted to come back, and almost all of them have come back for a repeat trip.
And Tom, how do you communicate? What languages do you speak?
Mostly in Arabic. So I speak, I mean, very poor, but I speak enough Arabic to communicate with the patients and the staff. The staff all know English. And with the patients, I speak mostly Arabic. I speak a little bit of the mother tongue, the local mother tongue, which is Tira, which is, obviously totally different from Arabic. I speak a little bit of that language, but mostly in Arabic is how I communicate with the patients.
What is Nasima's mother tongue?
Tira. So her tribe is called Tira, Tira, and that's her mother tongue. And I know a little bit of that language just from talking to her and some of the staff and patients. That's the predominant local tribe here.
Back to the surgery question and the training issues, someone asked, would you consider sending one of your medical officers away for surgical training?
Right. So yeah, I think that's probably in the works. Like Martin is interested in surgery, and I think after he works with us as a young doctor for a few years, he'll be ready to go off for a surgical residency training program, and I think we'll probably send him off for that so he can come back and be a fully trained surgeon. So I want to lay some groundwork with him now on the job trained surgery, but I think in the end it'll be good for him to get kind of official training and official papers as a recognized surgeon in the East African community.
What's the COVID situation there?
Very good, actually. We have one case, John, still. We have one guy that we admitted several weeks, now it's been about a month. We admitted him with what looked like a pneumonia. You've seen COVID, so you know more than I do. Looked like a pneumonia, typical chest findings, fever. Put him on antibiotics, wasn't getting better. Finally, it dawned on somebody, well, maybe he's got COVID after he'd already exposed everybody. So we shipped him outside and put him in isolation. He's still with us. He's been on oxygen for the better part of 3 weeks. He's doing much better now. Now most of the day he's off oxygen. We keep him on for a few hours at nighttime. Nobody else has been infected. We haven't had any other cases which look like COVID. The only test we have is an antibody test, which is very poor. So we're not testing people because it's just causing confusion. But he seems to be the only case we've had, and we're just keeping our fingers crossed that it stops at that. We'll see. I mean, the good thing here is the lifestyle of people here is everybody's outdoors. There's nobody actually lives indoors. Like nobody stays indoors for any period of time. So I think transmission of the virus will be less in our setup. Still, we're preparing ourselves. We're taking precautions. We're screening everybody that comes to the hospital for COVID. And we have a clinical officer set aside that does screenings and interviews for them. So we're prepared and ready if more cases come, but so far we just have one case.
I think that in the shipment that we're sending you, which I believe is still en route in various places and parts, I think there's some COVID antigen tests there. It's not perfect, but it may help you a little bit. You said he'd been on oxygen for weeks. I know that your supply is extremely limited. Could you talk about that?
Right. So for oxygen, we don't have tanks. We have what are called oxygen concentrators, which I know you know what they are, but for those who aren't familiar with them, it looks like a little box, and it takes ambient air, it spits it through some filters and other things, and it spits out fairly pure oxygen through nasal cannula. And that's the only practical solution for us. So we've got a few oxygen concentrators, and all we need is power for it. And that's what he's been on. And that can go pretty much continuously. We have to replace, it's a backlight filter of some sort. We have to replace that at some point, but it's been working pretty well. We have a very good missionary technician with us here, Chris Lowe, who's kind of helped us. He's repaired all of our oxygen concentrators and set up a little socket where he can plug it in out in there. Actually, the guy, his isolation, the only place we could find is right next to our generator house, is the only place where we could put him that had a room with an outlet. So that was a storeroom for charcoal. So we took all the charcoal out, put a bed and a patient there, and now that's our isolation room. We're in the process now of building 2 isolation wards. We got some money through WHO, and Chris and his team just put up 2 isolation wards, which are about finished. I think in the next few days they'll be done. So any new patients that come with COVID will stick over in the isolation ward. And that's a big thing for us now.
Yeah, we had a brief discussion with Chris about the possibility of maybe hooking up a system that could fill some small cylinders that would involve a compressor, those portable concentrators you talked about, and a small compressor. We'll have to revisit that. But is that something you're still thinking about? Some system like that, maybe to provide more oxygen?
Yeah, we are, just so we'd have basically a buffer. You know, our worry is, my main fear now is we got, say, 10 people at a go, and they all needed oxygen. We'd be really hard pressed. Number one, we don't have that many oxygen concentrators, but even our power supply, it's all on solar. We have a backup generator, so we could manage to do it. But that would really drain our power supply. So if we have some way where, say, during the day, when our power use is very low or the sun is up, we can just, even by solar power, we can fill some cylinders with oxygen, and then during the night, use those oxygen cylinders to oxygenate the patients. I think that will be a huge help. So we're still interested if that technology is readily available and something we can manage to do.
So I'm going through some questions, some good questions that are coming in. One question is, do you see HIV AIDS, and how do you manage that? And also, do you have a blood bank at the hospital?
Mm-hmm. So first question about HIV AIDS, we do. We're nowhere near the level that, say, you are in Kenya, or where, I remember when I was in Kenya, it was half your clinic day was with HIV patients. Our rate here is still low, but it is really climbing exponentially. And the problem we face is, I currently have, we've got about 42 patients that are on HIV drugs. We've got about 50 or 60 more that need the drugs that we can't start because we don't have the supply. I know, through you, John, we bought some HIV drugs at huge expense. Those lasted like a month; they were gone. Now we're getting some supply through the Ministry of Health in South Sudan, but they send very small numbers, and it's just never enough. The problem is we don't belong to any country. We're in rebel-held territory. We don't have access to the Global Fund for HIV and TB. We don't have access to WHO for the most part. So we're kind of on our own. We're trying to scrounge drugs from South Sudan, but really we're hoping that if peace ever comes here, we can enter into a real program with the Ministry of Health in Sudan, and they can supply us with drugs. It's a big problem right now. We have a lot of people that need HIV drugs, and we can't supply them. Blood bank. We have a refrigerator where we store blood. The problem with blood here is probably the same as a Kijabe. If a patient needs blood, we have to go to the relatives to ask for it. We don't have that much. Our blood bank might have at any one time maybe 5 or 6 units that are there. So if somebody needs blood, we really have to push the relatives to give blood for their patient. Many people are very hesitant to give blood. I mean, I don't understand quite why. We've had people here where parents, a mother and a father, will not give blood for their own child. And that's the culture here. People are terrified of giving blood. They think if they give blood, that they're also going to die, and who's going to take care of the rest of the kids. So we've had cases where a child is really anemic from whatever. He's bled out, or he's got malaria or whatever. And the father will say, nope, I'm not giving blood. Like you're just dumbfounded. Very difficult to get blood from relatives. But it's the only way we can get blood. We don't have blood drives where people will come, like communities will come and give blood that we can store. As you can imagine, if there's difficulty to get it from the relatives, it's difficult to get it from strangers. So it's something we're working on with the community to try to normalize blood giving, but we have a long way to go still.
And what's the timeline for the training school?
When we'd like to get started?
Mm-hmm.
We would love to start this year, 2021, but it's probably a bit optimistic. Probably realistically starting early 2022. I was just talking with Chris before. if we could maybe just start with clinical officers, which is probably the biggest need. We might have enough people in place now on the ground to start that training this year, and maybe pick up midwives next year. So we hope either latter part of 2021 or maybe more realistically 2022 at the beginning of the year, really start in earnest with this training school.
We talked about the training school. I know that you talked about oxygen. I know that you're soon going to be expanding the surgical capacity to 2 operating rooms. Are there other big plans, or what are the other aspirations for and needs for you and Mother Mercy Hospital?
Well, another quick one is kind of along the same line as the operating room, is we'd like to have a separate operating area for Caesar, who's our eye surgeon. Right now he's actually operating in a meeting room. So his eye setup for eye surgery is in one of our meeting rooms because we don't have space anywhere. And he's doing a great job with that setup. But we'd like to get another small operating room for him, separate from the main theaters. And then I think beyond that, we'd like to expand with the outreach clinics. Right now, we support 7 outreach clinics. By support, I mean we provide the drugs for them, provide some technical expertise. We have an outreach team that goes out and visits them. They do training for the local staff there. They do training for the community health volunteers. And we supply clinical officers. Right now we have 3, soon to be 4 clinical officers that work at these outreach clinics. We'd like to expand how many clinics we can support. So like in Nuba now, there are maybe 180 clinics, physical clinics. Some are just kind of straw structures. Some are a little more permanent. And then, I mean, literally like 10 of those clinics have no, not even 10, 6 of those clinics have a clinical officer. So we'd like to support more of those clinics with either drugs and or clinical officers or physical support. So I think that's one of the directions we want to go, is do more with the outreach clinics.
And one thing I'd say to our listeners, I know that when you had the measles outbreak a few years ago, it was really your outreach team that put an end to that. Once measles vaccine became available, they went out there, not only vaccinated kids against measles, but against pneumonia and hepatitis and everything else.
Mm-hmm. Right, exactly. And I think it's very important for us. We tend to get very, very closed-minded because we're at the hospital. Everybody comes to us for their problems. But I still think we're just seeing the tip of the iceberg with the problems in the mountains. I think most people, the vast majority, don't reach us. And I really want to get our tentacles out deep into the villages where we can get trained personnel out there, seeing people at the village level, really providing good quality care at that level. And really us being just a referral hospital. So people that really need our service now can come to us. So, we're not seeing minor complaints and other things. All that's taken care of at the local level where they have enough drugs, they have really well-trained personnel to do that. So I think that's really one of the main directions we want to go to in the future, is with the outreach program.
I think the last estimate that I saw from a policy group was that Nuba had a population of around 1.3 million, but I know that there are people from northern South Sudan who come to you, and now you're drawing people from the northern parts of Sudan and Khartoum. So, what do you think your catchment area is? I mean,
it's got to be several million. If you throw in, like you're saying, we throw in all of the northern part of Sudan, and we throw in the northern part of South Sudan. So we get a lot of Dinka coming from the upper part of South Sudan, but come all the way up. People that live way beyond Ida refugee camp. The Dinka Nuer will come from Bentiu. We had a guy from Bentiu come last week. So these are fairly big towns in South Sudan. I mean, really far away from us. So if you include all these areas, you're talking about several million people that come from these regions.
Back to about you and your family. What's your physical safety there now? How secure do you feel now?
Pretty good. I mean, like in terms of threats from the Khartoum government, pretty low right now. There's no sign of any active fighting. There's no sign that there'll be a resumption of hostilities anytime soon. You usually get a fairly good warning. If things are going to heat up again, I think we'll get a pretty good warning that things are going south again. And right now, things are pretty calm. Again, no peace agreement. They're still pretty far in terms of coming to an agreement, but no real sign of hostilities right now. So physically, I think we're doing fine. We don't worry about that so much at this time.
Well, I've gotten through a lot of the questions that people have put into the chat box. If there are a few people before we close and let Tom get back to his home, there are a couple of people who want to unmute and ask Tom a direct question. Now would be the time.
Tom, I just was hoping to ask how you're viewed by the village leaders or whatever other political systems are in place. Are you kind of viewed as an asset? Are you viewed as a blessing? Are you viewed as a curse? How are you viewed by the local political leaders?
Yeah, that's kind of a hard question for me to answer. I would say maybe in a simple word, maybe more of an asset. I would hope. I think not only me. Let me not talk about myself, but I think us as a hospital, in the broader sense, certainly the SPLA North leadership, I think very, very much appreciates what we're doing. They know what it was like during the previous Civil War, when there was no hospital and when they had wounded soldiers and wounded civilians, and there was nothing they could do. And now with the more recent Civil War, when they had a hospital they could go to and have an operation and be taken care of, these guys know the difference, and I think they really, really appreciate our presence.
Thank you.
Thank you. John, I want to answer a question I saw about tetanus. If I may just throw something in, just anecdotally.
Sure.
It's interesting that question came up because we have tetanus here. Obviously, we're trying to immunize everybody against tetanus, but the vast majority of people still are not immunized against tetanus. So we had a young girl here about 3 weeks ago. She fell and broke her arm, a very simple closed fracture. She went to a local bone setter. She lives quite far from us. Went to a local bone setter. He put her in a splint and tied it very tight. And what happened is the guy cut off all the blood supply to her arm. And by the time she came to us, the arm was completely rotten. You could smell it, 1,000 miles away. So that night, she came on a Friday. We're in the operating room. So that night she came. We took her to the operating room immediately. We amputated the arm, did a high amputation on her arm. The next morning, I went to see her on rounds, and I saw her neck kind of jerking backwards and realized that she was in tetanus. And we started treating her for tetanus, and she died later on that day. So that just kind of highlights a few things. One is access to care. If she were brought to us immediately, that would be a very, very easy fracture to manage. So both access to care and lack of vaccinations of the population. She died of a preventable disease, which is tetanus. It was a really a very sad case.
One thing for perhaps the non-medical people to understand about tetanus is that you do get a vaccine when you're a young child, but then you're supposed to get a booster. I mean, many people know that, but here, often those boosters aren't given. So, even in Kenya, which has a lot more resources than where Tom is, we do see, teenagers or older people with tetanus because they never got their booster shot. And the story that he tells of the cutoff of circulation to the arm, I've also seen that. I have a colleague in another Central African country that's seen that. It's unfortunately a common problem when young kids break their arms, that they don't get expert care or really competent care when they're first seen. Back to a couple of other questions in the chat box. One is, are local markets opening? Do you have access to any goods? Is fuel available to you?
It's getting better, John. Now you can, local markets, you can buy quite a few things. I mean, but food items are very limited. I mean, you can get dry food, sorghum. You can get rice sometimes, sometimes even some pasta, salt, sugar, basic things. They're just all open air markets. You can buy fuel. It's very expensive and it's often very dirty. So if you need fuel, you can get it, but it's very expensive. Now there's a bit of a kind of a semi-legal market operating with the North, where you can buy more heavy-duty things. You can buy cement and metal things. That's pretty new. That's actually new over the past few months. Before that, you couldn't get anything. You couldn't get cement or metal stuff or iron sheets or anything to do any building with. So that's opened up quite a few things. So the markets are slowly getting better and opening up. Things are much better now.
What's your diagnostic capacity at the hospital? What kind of lab and what kind of X-ray do you have?
We've got a pretty basic lab. We can do a complete blood count for those that know what that is. So we can check somebody's blood level. Actually, now we don't have a reagent, so we can't, but usually we can. We can do a urine test, basic stool test. We can check for TB, we can check for HIV. We can do blood film. We have patients, we have a lot of cancer here. We have quite a few with leukemias. We can look at the blood film and determine if they have leukemia or not. Pretty basic in lab. We have a plain X-ray, which was donated by Sudan Relief Fund a few years ago, and that's fantastic. It's a very simple kind of mobile model. X-ray works very well. It's digital, and we have a few ultrasounds, and we use that all the time. We have both the kind of more fixed ultrasounds. We have a little butterfly model, which was brought out by Jim Peck and give it to us, and I use that all the time on rounds. A little kind of on a little smartphone kind of thing. So ultrasound is probably our most commonly used test. We did, I don't know, 2,500 ultrasounds last year. X-rays, we do quite a few X-rays also. We have the guys that take those are our operating room technicians, are the guys that take our X-rays. We taught them how to do it. They do all those now. So pretty limited diagnostic capability, but it's enough. It's enough for what we need for the most part.
And are there any other hospitals? You mentioned the clinics and the lack of healthcare personnel at those clinics. Are there any other hospitals in Nuba?
There's a smaller hospital. There's one run by the German emergency doctors. They're about an hour and a half from us. They're what we call a small hospital, and they refer surgical stuff and more complicated case to us. There's another one started by a Nuba doctor, Dr. Ahmed, down in Jageba, which I think you're familiar with. That's still kind of in the process of growing. They are seeing some patients there, but they're still kind of they're functioning, but still kind of growing a bit. And that's pretty much it. The rest are kind of small clinics with very limited drug supply, very few personnel.
And you're the last in the line, right? I mean, there's nowhere to refer from where you are.
No, it's pretty much a moot point. We have, now that you can access Khartoum, it is theoretically possible to send someone to Khartoum, but practically no, they don't go for a number of reasons, usually from cost. They can't make it up there. And oftentimes when they get there, they just get, I don't know what it is, they just seem to get lost in the system and they don't get the care that they need. Usually the rate limiting factor now is cost. They can't afford the care there. They can't afford the transport. So for all practical purposes, we're the final stop for somebody.
Well, again, I want to be respectful of everyone's time, including Tom. I'd like to close by thanking Tom for taking an hour out of his very busy schedule that we heard about. And I would also very much like to thank our friends and supporters who are on the call. The people who have come alongside Tom are just truly remarkable. Those who volunteered both their time and their resources. We're so grateful. You were amazing before, and with COVID, it's even more so. So it's really your generosity that's keeping the hospital going. And you've heard Tom speak about it. And so thank you very much. Tom, is there any closing words you'd like to share?
Yeah, I just want to say a sincere thank you to everybody out there. I want you to realize that we're only here working because of you, and that's not, I'm not trying to blow smoke. The truth is, without individual donors like you, we close the hospital, and none of these people get anything. So that's the God's honest truth. So from the bottom of my heart, on behalf of the people here that you don't know, I thank you very sincerely for what you're doing for us, for allowing us to take care of people here. Without you, we can't do anything. And thank you for that.
And John and Tom, if I can, this is Scott from AMH as well. Tom, it's a privilege for us, for AMH, and I think for everybody on this call, to support you. I can't imagine an investment that is a better investment that we could make in people's lives or in healthcare than what you accomplish. And so we want to thank you and encourage you. And all of you that support Tom, I want to echo what was said. Thank you. He couldn't do it. We couldn't do it without you. And we encourage you to keep doing it. As you heard, Tom has big dreams. A lot of things left to do in the Nuba region. And as peace comes, it actually will create opportunities that I think could be even more amazing, believe it or not, as Tom can reach so many more people. So please continue. Thank you. We're so appreciative. And for those that were asking, we are going to send out a recording of this to all of you. And I encourage you to share it with others. If there are those that you know would have liked to have been on that couldn't, or just people you want to introduce to Tom. He's such an amazing person. I know you would never say that, Tom, but we can. And just people hearing him for himself is wonderful. So please feel free to share the recording and let us know if we can help you in any way to share all that Tom's doing. So thank you, Tom, and thank you everyone for joining today.
Great. Thanks, Scott. Thanks, John.
Thank you. Okay, Tom, we'll release you and bring it to a close. Thank you.
Absolutely.
All right, man. Right. Same to see you. Same to you, Scott. Thanks to everybody.